Perfect. Let's get started. So we talked a little over a year ago, and it's nice for you to be. I know that you've been very busy. I should probably say that we exchanged notes over the course of the week, and the notes that you sent back to me were the timing on that email was 2 in the morning. Have you slept at all in the last year?
Yeah, occasionally. It doesn't feel like it's been a year, Paul. It's either been a month or 6 years. I can't tell which.
Lifetime or a lifetime. Have you developed any conflicts of interest that we should disclose before we talk
Uh,
today?
I have none that are relevant to this.
You haven't had time to eat, let alone develop side gigs. So let's talk. So we've learned a lot about SARS-CoV-2 in the last year, and I think that some things have been very expected. Some things have been less expected. So what do we know about SARS-CoV-2 that we didn't a year ago? What do we know about the transmission of this virus that we didn't know before?
There's so much that we've learned, and so many things have really surprised us. A year ago, we were really focused on droplets and fomites. Remember, that was back when people were wiping down their Amazon boxes and leaving their groceries out for a day to
Couldn't buy
disinfect.
wipes in the stores.
Yeah, and we've learned that although droplet transmission probably does occur under extreme circumstances, is really just not a very important part of transmission. So all spraying down of sidewalks and the cleaning of surfaces has probably played either no role or a minor role. Hand washing is probably still important, but really this is a shared air virus, and it seems that the vast majority of transmission occurs from droplets at close range, but in some circumstances, there is transmission at a longer distance. Now, I don't really want to get into the whole what constitutes a true aerosol and what's the aerodynamic diameter definition. It's not measles. It doesn't stay in the air for 2 hours after a child has left the waiting room. But in situations like a choir practice or people shouting, there can be transmission at a distance, but most transmission occurs within 3 to 6 feet, and it occurs face to face. And importantly, one thing I don't think we really appreciated until probably well into last spring was how much of a role asymptomatic transmission plays. People are most infectious for several days before their symptoms begin, which is a little bit different than any other virus we deal with. Flu, you're potentially infectious for about a day before symptoms begin, but without the cough and sneeze that go along with symptoms, you don't transmit flu very effectively. SARS-CoV, not the same thing. Our asymptomatic patients are really important sources of transmission.
Do we know about how important the severity of symptoms is compared to the viral load that you have? Is somebody more contagious if they have more serious symptoms?
There have been a few papers that have suggested that there's slightly greater transmission from more severely ill patients, but it's not dramatic and it's not clear cut. Likewise, viral load studies have been kind of all over the place, and part of that's for technical reasons. You know, measuring viral load in blood is easy. It's always the same amount. But when you sample the nose with a swab, you get variable amounts of material, you get variable amounts of cells, so that, you know, part of the problem with many of these studies is just the quality of the measurement of viral load. That said, you've got a lot of virus in your upper airway for several days before your symptoms begin, or for the first several days of an asymptomatic infection. And during that time period, you're quite infectious. What we don't really understand is why some people seem to participate in super spreader events. Sometimes we know that it's kind of a social aspect. So let's imagine you have a party in the garden of a big white house, and everyone is clustered together celebrating the appointment of, let's say, a prominent person to a prominent political appointment. The gathering of people together intensely and the intermingling is one way that you get a super spreader event. But the other seems to be these more unusual circumstances, like when people are together singing. And singing seems to be quite important in creating very effective transmission.
So I'll avoid both elite events and singing for the next while. Do we? The it does seem that one of the things that people have said is, I'm not likely to get very sick, so I shouldn't worry about this. But it's also become quite clear that the less sick have also been avenues for spread of the disease more broadly. Is that not true?
It's absolutely true that a lot of this epidemic is driven by people with mild disease or asymptomatic disease, and also by age group. We know that, in the US and in Utah, that high school and college and young adult age people have played an important role in the spread of the epidemic, and they've been impacted with a lot of infections. But by and large, in the past, they were not the ones ending up in the hospital. That's not entirely the case that we're seeing right now. In a number of countries, as well as in Michigan, there's been a big shift towards younger people being hospitalized. Now, the next question is, why is that? So one reason is that we have very high vaccination rates in older people. So it's just simple math. More vulnerable people are younger people, so they're more likely to be the ones who end up with severe disease and get hospitalized. But it's very much an open question as to whether the variants are causing more severe disease in younger people. And by younger people, I'm not strictly referring to children, but people under 45.
Which is, yeah, I think the age that tends to feel more invulnerable anyway. We've also learned a lot about the range of symptoms and complications that come from this disease. What things should we be thinking about?
Wow, this disease has been really incredibly eye-opening. And if you start at the top of the head and work down to the feet, there are these unusual manifestations. We've seen neurologic injury, we've seen stroke, we've seen other types of thrombotic disease. There's of course the very unusual manifestation of loss of taste and smell, which is unusual in all other diseases, but pretty common in this disease. There are pulmonary emboli, but there's also microclots in the lung leading to permanent respiratory illness and damage. There's been cardiovascular disease. Of course, I think we've all recognized that abdominal pain can be part of the presenting picture, particularly in kids, and particularly with MISC. And then if you go all the way down to the toes, many of us have seen cases of COVID toes, which is pernio or chilblains-like lesions, only now we're seeing it in young people at any time of the year instead of seeing it predominantly in middle-aged people in cold climates in the winter.
Are we seeing more symptoms more longer from the time of the initial illness as well?
I think everyone's heard about long haul diseases. It was originally called, now referred to as long COVID, or probably the best term is post-acute symptoms of COVID. And that's really turning out to be one of the very important parts of the story. We don't fully understand it. And in children, we really don't understand it very well. But depending on what study you read, up to 50% of people have significant symptoms 60 days after recovery. Now, that's probably a slightly high estimate. It may be lower. And for kids, we really only have one or two studies. But people are experiencing fatigue. They're experiencing ongoing shortness of breath and decreased exercise tolerance. Some people complain of what's being referred to as brain fog, which is really poor concentration, poor memory, difficulty functioning. There are, of course, people, some of whom are very young, and some are professional athletes who've had cardiac dysfunction that persists for several months. And I think this is really the public health sleeper problem that we're going to have to deal with. And as pediatricians, we really need to understand the impact on kids, because the long duration symptoms do not appear to be related to severity of the initial illness.
And can have a lifetime of impact, unfortunately, it would seem.
Yeah, I mean, we hope it's not a lifetime. The people who are starting long COVID clinics are seeing that many people do get better with time, but we haven't had enough time to really understand the natural history. And if you think about it, for a high school student, 3 or 4 months of not being able to have the energy to get through a day of school, or the concentration, or not being able to participate in their sport, can be absolutely devastating and can have, many years of repercussions.
Right. And I think I'm just sort of progressing forward there because we really don't have any information that goes beyond a year or so after any illnesses right now. And so I'm sure conversations 5 years from now will also tell us more things. I would have to say that looking at my patients, even just the absence of smell and taste in some of my patients, which has lasted now for several months, is very intrusive.
Yeah, yeah. Of course, the people who make the paper are several chefs who've lost their sense of smell and still can't taste things properly and basically have lost their career for now.
Yeah, yeah. I read a piece about somebody who was doing smell retraining to try to get back on track. Um, so, what are the importance of variants currently? Because it seems to me that has shifted the conversation about herd immunity.
This is a very complicated subject, and I'll try not to bore everybody because I love the subject. But it starts with the fact that this virus jumped into humans less than a year and a half ago and is evolving. And it's evolving in ways that suit it, that give it a selective advantage. And what we're seeing is that a number of distinct genetic lineages of the virus have acquired traits that make it a more successful virus. And this has happened in parallel through different lineages, which really tells us how effective these changes are in giving the virus a selective advantage. So the first lineage that really got a lot of attention was the variant that emerged first in the UK, and we call it B117 or B.1.1.7, very mellifluous term.
Like Star Wars, let's be honest.
Yeah, I know. We should probably just call it Hugh or something very, evocative of its UK origins. And this is the one that now has become the dominant strain throughout the US. It is the most common strain of virus that we're isolating right now in Utah. And it has evolved a couple of features that are really important. The most important one is that it spreads more easily. It's about 50% more transmissible. It also appears to cause slightly more severe disease. And those data are slightly conflicting, but on balance, it looks like it really is a little bit worse. It's not dramatic. It hasn't become Ebola or anything, but the transmissibility is a huge issue. We're seeing that in a couple of ways. It means that in order to stop the spread, we need much better barriers. And those barriers could be, social protective measures like masking and social distancing, or it can be having a large percentage of the population that's immune. The basic epidemiologic math says the more transmissible the virus, the higher the proportion of people have to be immune to reach herd immunity. And I put air quotes around that because, it's not an all or none concept, and it's actually a very complicated concept. But what having a more transmissible virus means is that we're going to have to get more people to have vaccine-derived immunity to really stop transmission. The other part of the story is that it does appear that for some of the variants, not so much for 1.1.7, but for 1.351, which is the variant that emerged in South Africa first, or P.1, which emerged in South Africa, or this new variant that is now spreading rapidly from India throughout the world, that your immunity that is derived from an older virus is not as completely protective. So people who were infected let's just say last November, may be somewhat protected against exactly the same virus they had in November, but they may be quite susceptible to some of these variants. And in 6 months from now, they may be very susceptible to some of these variants. The good news is that the vaccines seem to provide substantially better immunity against the variants than natural infection does.
So message number one is if you've been infected, you should still be immunized.
Absolutely. And the good news is that people who were infected who get vaccinated seem to have even better immunity than people who just got their 2 doses of an mRNA vaccine. That's not a reason to go out and get infected. It's a very good reason to get vaccinated, even if you have been infected.
A hard pass for me on that one. So yeah, I'm immunized and grateful for it. How protected should I feel by the immunization? How much is that get out of jail free card?
Yeah, it reminds me of the line, are you feeling lucky, punk? risk. These are really great vaccines, and the protection is really, really good, but it's not perfect. No vaccine is perfect. We're now seeing a lot of good field studies that are showing what kind of protection you get in real life. And if you're a relatively healthy person, you're protected about 90 to 95% against symptomatic disease, almost 100% against lethal disease, against dying, and maybe 60 to 80% protection against asymptomatic carriage for at least the first 6 months. But you can sense there's a but coming here.
Yes.
We're learning more about people where that story may not be quite the full story. People on a lot of different immunosuppressive drugs have much more blunted responses. People who've had transplants, more than half of them don't respond to the vaccine, according to a recent study. In the older age group, and I'm going to redefine that upwards, but in the frail elderly, it looks like immunity may be fading and protection may be fading somewhat faster than it is for, the spry young 60-year-olds and other young people.
So practically speaking,
so I didn't answer your question. I gave you a lecture, but I didn't answer your question. Yeah. So I think you have to combine protection with risk of what you're doing. And I think if you're vaccinated, if you're in a relatively low risk exposure situation, you should feel very protected. Any outdoor activity that doesn't involve being in a heavy scrum of people, being indoors with other vaccinated people, being indoors with a mask on or in a well-ventilated, well-distanced space. I think the protection is really, really good there, and you can feel pretty comfortable, but not immune. It's not complete. I think that as you get into a riskier and riskier situation, and as you think about your own ability to respond to the vaccine, you have to temper it. If I was on an anti-arthritis biologic, I would not be going to restaurants. I would be very careful about gathering with anyone who wasn't vaccinated. Whereas if I was a 16-year-old who was vaccinated, I'd feel pretty invulnerable.
So a certain amount of gathering together is probably safer at this point. By being outside, basically, going back to what you said at the first, we've basically diluted the amount of air that we're sharing. And so being in an outdoor space with fewer people should feel safer. How about travel?
Yeah, that's the $1 million question, or I guess it's a multi-billion-dollar industry.
Right.
I think it really depends on the type of travel. I think if you're vaccinated and you are careful about how you get to and from an airplane and everyone's wearing a mask, that's probably pretty safe. And the issues that I would worry about are at the other ends. How do you get to the airport? What are the crowds like in the airport? What are you going to do when you get there? Are people wearing masks? Is there a high rate of vaccination? No amount of vaccination would make it completely safe to get on a 14-hour flight and land in Delhi in the midst of a huge outbreak. On the other hand, flying to Chicago right now, if you're careful about how you get through the airport and you wear your mask, is probably pretty safe for vaccinated people.
What about going to the gym?
Great question.
In gyms, I have seen a lot of heavy breathing in gyms.
Yeah, and full disclosure, I love going to the gym, and I haven't been in 15 months, and I'm not going back right now. So that should temper my response a little bit. Gyms are places where there's a lot of heavy breathing, and they can be crowded. And the typical gym does not have great airflow and great ventilation. So I think and there've been many super spreader events in gyms. So I think on average, gyms are not that safe. There are probably ways in which you could feel much more comfortable. A gym that has open windows, that limits the number of people who are in there, that requires people to wear masks, is probably pretty safe. A really crowded spin room where people are, breathing 40 times a minute and there's terrible ventilation, they're not wearing a mask, not so much.
And it turns out most gyms are actually built in storefronts that aren't really designed for all those things. What about hugging elderly relatives? Can people start hugging again?
Yeah, time to hug. I think, when both people are vaccinated, hug at will. That's great. I think what we've talked a lot about is, and CDC's talked a lot about, is what about when the person is really vulnerable is vaccinated, but they want to hug their grandkids? And I think uh, that's probably pretty safe. The person who's most at risk has vaccine protecting them. The person who might be carrying virus isn't going to get terribly sick on average. And it's really important to hug your grandkids. I think the benefits outweigh the risks in most situations there.
We're going to spend a whole lot more time talking about kid-specific stuff in the next episode, but that's clearly in the overlap. Let's just close by talking a little bit about the vaccines, because I have to confess, full disclosure, it makes me nuts when people say, "I don't want to take the risk of a vaccine," but I think this is a virus that has turned out to be plenty risky by itself. Can you comment on some of the vaccine related things? How safe are these vaccines?
By the standards of vaccines, they are very, very safe. There's always some risk with any medication. We always have to say that. And with vaccines, there are side effects we have to acknowledge that occur at very, very low frequency. For the mRNA vaccines, the only really serious side effect that's occurred has been anaphylaxis at a couple of cases per million vaccinees. Which is a rate of anaphylaxis that is substantially lower than what we see for hospitalized patients who are getting 3 or 4 medicines that we give them. Mm-hmm. So, that's the kind of risk you have to measure it up against. For the J&J vaccine, where there is no risk of anaphylaxis, there is this risk of unusual thrombocytopenia associated blood clots, predominantly in women of reproductive age. In men and in older women, the rate is below 1 in a million, but in women between 18 and 49, it's currently estimated about 7 per million. Well, what does that mean? It's about the risk of getting struck by lightning if you live in the Intermountain West. And that's not a joke. That's roughly the number of lightning strikes that we have per year in this area. It's not zero, but compared to the risk of dying of COVID, which has killed 570,000 Americans out of 330 million, which works out to be about 1 in 7,000 of us has died so far. Now, I know probably talking in numbers isn't the right way to talk to our patients.
No, I get it. But in some ways it is, because looking at it as a matter of scale, the risk is clearly much higher from the disease than from the immunization. What about the fact that this the fast track approval process, should that raise any fears?
It should. I mean, it's a legitimate subject to bring up, but I think when you look at what actually happened, you can understand that really at this point, we have as much safety data as we have on almost any vaccine. Most of the fast tracking was done by eliminating red tape, by the gaps in the process. Normally you do phase 1, you wait 6 or 8 months to review the data and get your funding together. You do phase 2, you wait a year to find your sites to your phase 3 study. You get your phase 3 results and you wait a year to get your factories up and running so you can produce it. And they just took all of those interstices out of the process. And they still reviewed trials that were quite large and that had at least 3 months of follow-up. But that was the trials. That was December, what we knew back then. Now we've got 185 million Americans and several hundred million more people around the world have received these vaccines. We're doing a really good job of trying to collect all the safety data that we can, which is, of course, how we discovered the blood clot issue. The royal we, but I used to be part of this vaccine safety network years ago, so I still say we. And so now we have safety data on 180 million people. That's pretty good. That's probably most of our childhood vaccines don't have data on 180 million people for the first 20 or 30 years that we use them, because there are only 5 million births a year in the United States.
And the fact that the first two vaccines are an mRNA-related technology, these are not the first two vaccines that were studied using mRNA technology. Is that right?
Yeah, mRNA technology was in the works for about 20 years, and really coming into maturity in the last 3 or 4 years. So it's not a brand new process, and it was not unknown. It's not something that was completely created out of whole cloth for this. That said, I think we subjected these vaccines to a high level of scrutiny. That's why, in addition to the usual safety methods, they developed several other tracking tools, including many people who are listening to this probably signed up for vSafe and sent in their clinical status every day after they got their vaccine. And with that extra scrutiny, we were able to say with some confidence that these are extremely safe vaccines.
And should there be any concern in people's minds that the approval has been an emergency approval so far?
Well, most people misunderstand what emergency, what an EUA is, an emergency use authorization. It is fairly broad. It does allow the FDA to approve products when there's a reasonable chance that they will benefit and there's no alternative. But that's the minimum standard. That's not the standard they used for approving these vaccines. They subjected them to a full review by FDA. They had a full external review by a very cantankerous and independent board, the FAAP, the Vaccine and Related Biologics Advisory Group, which is a group of vaccine experts from multiple disciplines. And then they made all the data public. So this was really gone through an approval process that was pretty similar to what would be done for full licensure, with 2 exceptions. They didn't wait till they had 6 months of data. They approved it on 3 months. And they didn't wait until they had provided a lot of assurance about the production process, which is a very laborious and bureaucratic process that manufacturers have to go through. As I think everyone's heard, Pfizer has submitted for full licensure right now. They've done the extra hoops. They have 8 months or more of follow-up data, and Moderna will be doing that soon. So hopefully that helps people understand the EUA process a bit better.
And then in very broad terms, by the time this airs, the Pfizer vaccine will probably be approved down to age 12. Is that right?
Yes, and that is one of the best pieces of news we've had in the last couple of months.
No question. Will the other vaccines be close behind for that age group?
So as we record this, Moderna has issued a press release with their results, and they had no safety problems. They had excellent immunogenicity, and they were 96% effective in people 12 to 17 years old. They're providing that data to the FDA. So I anticipate Moderna is no more than 4 weeks to 6 weeks behind.
What about the adenovirus vaccines? Will they be approved for younger patients soon?
Well, those studies are ongoing. I think with the issue about blood clots, they'll be subjected to extra scrutiny, as they should be.
Sure.
And I think the approval process for J&J for younger people will be slower, just in order to be really, really careful.
Sure.
And it's possible that with good mRNA vaccines for younger people, the company will decide it's not worth the risk of getting it approved for younger age groups. It's a little bit of a shame, because you can imagine how much easier it is to vaccinate school-age kids if you can have a one and done vaccine program than having to bring people back 3 or 4 weeks later.
One and done and easier storage.
Yep.
And so in rough terms, can you speculate about what the timetable will be for even younger patients and how far down that younger will go?
The timetable is always a little bit subject to change. Right now, Pfizer expects to submit their data in September. That's for down to 6 months. I'm not sure that they will submit all of it in September, because the way you do these studies is you go down in age cohorts. So you go from 12 to 6, 6 to 2, and 2 years old down to 6 months. But we were surprised. We didn't think that we were going to see vaccination for 12 to 17-year-olds until June or July, and we're going to have it in May. So anything I predict is probably wrong. But let's say early winter is my best guess, and I'm going to put a very small bet on that. One beer.
Okay, how about jetpacks? When will we have jetpacks?
Yeah, I'm still waiting for my flying car from the Jetsons.
All right. Well, thank you so much. We'll take a break and then come back and talk some more about issues directly related to kids. Thanks, Andy, for being with us.
Thanks so much for having me, Paul.
Welcome back to part two of our conversation about COVID-19, SARS-CoV-2. A year ago, we were talking about this. 2 years ago, who knew, right, Andy?
Yeah, and even a year ago, we had no idea where we were going to end up. Who would have thought that, more than 500,000 Americans would be dead?
Right, right. And just right now, as we're speaking, looking at the situation in India, it is just so staggering, so staggeringly tragic.
It's really hard to find words for. It's almost biblical right now.
Yeah, I heard a conversation with a news bureau chief this week, and not meaning to be shocking or anything, but he said every morning he wakes up to the smell of cremation fires, and I just think that is just so incredibly tragic. Well, let's talk this week a little bit more directly about COVID-19 and kids, because it's been an interesting adventure, don't you think? I think going into this, we weren't exactly sure what the impact on kids would be. And I think we're still, to be honest, learning about what the long-term impact on kids could be.
Yeah, I think like all things COVID, we're still learning as we go. We started out expecting that this would perhaps be something that really spared kids altogether. And that turned out not to be true. It's sort of a good news, bad news situation. Children were not nearly as severely affected as adults. I can give some numbers on that in a second, but they were not spared. We spent this year at Primary Children's admitting children with severe disease due to COVID. Granted, those numbers were nothing like what you would see on the adult side. And most kids, thankfully, recovered very well. But there's been a pervasive myth that drives me and all of my infectious disease colleagues crazy that kids aren't affected and that there's no impact on kids. And that is total and utter bullshit. Sorry, can I say that on this podcast?
You already said, apparently.
We'll beep it out. Okay. You can tell it upsets me and many of us.
Well, and both on the kids directly, and I think the thing that has been most upsetting to me is how this whole thing has been a failure of our national empathy in some ways. I think that we've always characterized the great generations in the past as people who are willing to make sacrifices for the sake of other people around them. And I think that the pervasive message that we get is, look, if it doesn't affect me, I don't get why I should change my behavior.
Yeah, there's that. And there's also this sort of drifting upwards of what we're willing to accept. If it doesn't kill as many children as it kills adults, well, that's not so bad. CDC has recorded at least 300 deaths in children due to the virus, and another 100 and something due to MIS-C. Now, that is nothing compared to the toll it's taken on older adults. But that's more than twice what we see in a really extreme flu year. And in what universe is it okay for 300 children to die of a disease that we might be able to spare them from?
Right, absolutely. And I should add, this is a complete aside because I forget to do this every episode of everything I ever do. Or do you have any conflicts you need to disclose?
I get passionate about people ignoring children's health, but other than that, no.
As you should, right? Or you're in the wrong business.
Right.
So I think what we're seeing now is a spread of availability of vaccine to younger age groups. So currently to age 16, by the time this airs, it will be to age 12. Is it safe to say that you would recommend immunization of adolescents?
Wholeheartedly. And I would venture that within a week of it being available to adolescents, virtually every child of a pediatrician will have had their first dose of vaccine.
I think you're exactly right. Yeah, I think you're exactly right. There were two groups that I didn't cover when we talked last time. People who have been in clinic, nursing mothers have sometimes said they're reluctant to get the vaccine. Should they be?
Yeah, I think that actually when you're nursing is probably a very good time to get vaccinated. There is no vaccine that we know of that passes anything through breast milk that might be harmful. If you think about how much antigen is in the vaccine, it's 30 to 100 micrograms in your deltoid. How much of that is going to get into your breast milk? None, essentially. But what will get into the breast milk are antibodies against COVID. And although nursing infants have not been very hard hit by the disease, we'd like to protect them as much as we can because, we're never going to vaccinate children under 6 months, never going to be able to do that. So that's, I think, an area where it's a really easy answer. Pregnancy is a little bit more difficult because we have pretty good information on safety in pregnancy. We've been tracking now tens of thousands of pregnant women who've gotten the vaccine and have not seen any issues. The flip side of that is that we're learning more and more that being pregnant puts you at risk of having more severe COVID. So CDC just came out saying that they do recommend the vaccine for pregnant women. The one caveat that we still kind of have in the back of our minds is very early first trimester might not be the best time to get vaccinated because there is some risk of fetal malformation with very high fevers. And some tiny proportion of people get the vaccine may have a very high fever. So if I were a pregnant woman, which I will never be, and I'm mansplaining here, I might wait till 2 to 3 months into the pregnancy, but I would get vaccinated without a second thought.
What about women fearing infertility problems?
There is absolutely no scintilla of evidence that the vaccine has any impact on fertility. That is a bit of actively spread disinformation that has no scientific basis. There are things that we should legitimately worry about. Safety in pregnancy, we need to understand that we have a pretty good idea of where we're at, but we don't understand everything. But as for fertility, that's utter nonsense. Women are planning on getting pregnant should get vaccinated before they're pregnant, so they don't have to face the tough decision about when to get vaccinated during pregnancy.
And again, going back, we talked last week some about the technology involved. One of the things that people talk a lot about is, I don't want to have this RNA inserted into my DNA and changing my genome somehow.
Yeah, I know. And of course, it's hard to explain molecular biology in a 2-minute discussion about this. But I think as physicians, we all understand that mRNA is a transient molecule that is degraded in the cells, that it can't be integrated into the host genome. We can go into reverse transcription of viral RNAs. That's an unusual circumstance that can happen, but this is not the same thing. The mRNA from the vaccines is degraded and is gone. And so I think we can assure people this is not going to be integrated into your DNA. It's not going to change your DNA. It's not going to broadcast your thoughts to Bill Gates via a microchip. And I'm a little flip just because, I think these are fairly absolutes. There are areas in which we have to be careful because we keep our minds open about things like, could there be some side effect we haven't yet discovered? Of course there could, but will it change your DNA? The biology says that can't happen.
And again, emphasizing something you said in the last episode, these vaccines have now been administered to about how many people?
So I think as of today, when we're recording, it's about 185,000 Americans, 185 million Americans. Over 1 million Utahns have been fully immunized as of today, so with 2 doses. So we have an enormous safety database. If you add in another 100 million or so from around the world, we have a lot of experience now. And the example that I think I used on the last podcast is that when we vaccinate kids against rotavirus, we're vaccinating at most 5 million children a year, it would take us, 90 years to get experience of 180 million vaccines for safety. So this is a remarkable safety database.
And that said, it is extremely important that we study vaccines that we use. But I don't, it sounds like you have no hesitation about recommending these vaccines as safe and effective.
Yeah, and safety is not absolute. I don't want anyone to get me wrong. I think there are side effects that we know about, and there may be some other very rare ones, but COVID is a lethal disease. And if it's not lethal, it can make you very sick. And if it doesn't make you very sick, it can change your life. And if it doesn't change your life, you can infect other people and kill them. So measured against that, the vaccines are a no-brainer in my mind.
One of the things I think is important for us to keep in mind about the issue of immunization is how it changes things going forward. And given that by the time people can listen to you talking today, 12-year-olds will have access to the vaccine. Should that make a difference in what 12-year-olds should be able to do going forward this summer and into the fall?
Well, absolutely. I mean, if your 12 or 13-year-old is vaccinated, there are a lot of things you can feel pretty comfortable about they're doing. You know, going to summer camp, traveling on airplanes, hanging with their friends the way young people do, where they're in close contact and sharing sodas, et cetera. That really just gives them a margin of safety that's terrific for them. It is true that, you can say, oh, if my 13-year-old gets it, he'll probably be down for a week and then be okay. And that's true, probably. But what if your child is the one who gets sicker and ends up in the hospital? Or what if your child is the one who ends up with symptoms that drag out for 4 or 5 months and loses a year of school? And you have a safe vaccine that you can give them and protect them. So I think for our own children's benefit, there's a huge argument for doing it. But of course, there's another really important argument, and that is the role that children can play in bringing this pandemic to an end.
So is the pandemic endable without immunizing children and adolescents?
I don't think so. There's a lot that we don't understand about the end game of this pandemic. We really thought that within a few months of vaccines being out, we would be seeing almost no transmission. We wouldn't have small fourth surges. We wouldn't be seeing, 300 to 400 cases a day in Utah and a handful of deaths a day. So we don't really fully understand what it's going to take to end the pandemic. But we do know that we're going to have a really high level of population immunity, and it's got to be good and durable immunity. And the vaccines give us good and pretty durable immunity. Natural infection is less effective and less long lasting. We've gone back and forth talking about numbers that are needed for herd immunity, and that's changed a bit as we've understood the disease better and as the variants have increased the transmissibility of the virus. We now think that, if we really want to stop the spread in the United States cold, we would probably have to get somewhere between 80 and 90% of people vaccinated. We don't know if we can get there. We don't have a chance if we don't include adolescents.
Looking at summer, because this is available in the early summertime. We talked a little bit last time about travel. Many families are going to be in a situation where some will be immunized and some will not be. What can they do for vacation?
That's a really hard question, Paul. There's some things we talk about safe, but we really should talk about safer. Unsafe, safer, and safe. Things that you do outdoors predominantly for unvaccinated people are really quite safe. So taking that camping trip, taking a car trip to the national parks, I think is definitely very much on the safer side. Going to a huge family reunion that mixes a lot of unvaccinated people, particularly if it's going to be indoors, not so safe. Going to a large indoor wedding for your unvaccinated kids, not so safe and not something that you'd want to think about. And, we always think about air travel when we think about vacation as well. And I think it depends. For vaccinated people, where everyone's wearing their mask, I think air travel is becoming reasonably safe. For unvaccinated people, or if mask use starts to fall off, I think it is a little bit more dicey. And then it's going to depend also on duration of travel. 12 hours in an airplane is a lot different than 2.5 hours in terms of risk.
Mhm. And as you mentioned last time, what happens at the beginning of the and the end? You know, how isolated can you be in an airport? How is the hotel lobby where you show up? What are all of those things?
Yeah. I haven't been in an airport in 15 months. And I've been, a diamond medallion for years. So I normally live out of a suitcase. So this is really different for me.
You've had your wings clipped in so many ways, haven't you?
Yeah.
You've looked at COVID and not much else. Speaking of which, the experience during this past viral season has been unique. I would guess that's been the case of primary children's. Care to comment on that? What happened with the other viruses this winter?
Well, they went AWOL. They disappeared. RSV did not show up this winter at all in North America. Flu showed up, but in staggeringly small numbers. There was very, very little flu anywhere. And why that is completely understood. The easy explanation is that, kids weren't mixing, we were wearing masks, we were social distancing, but the impact was so dramatic that it makes you wonder what other explanation there might be. Is there some form of viral interference? That's a hot area of research. What it's really interesting to bring up RSV, because of course that meant that we were able to take care of all the kids with COVID, and we had a pretty reasonable winter at the hospital instead of it being crowded to the rafters as it often is. We worried that if we had flu, RSV, and COVID, we couldn't cope. But thankfully we were spared because RSV didn't show up. RSV showed up in the Australian summer, and it showed up fiercely. And so back in December and January, during their hot months, they had a very bad RSV season. And we're now hearing that there are pockets of intense RSV activity in the United States. Some places in New York, some places in Florida in the last week have started to fill up their hospitals with RSV patients. It's very sporadic so far. We don't know whether it's going to spread around the country during the summer or wait for winter. We're really on tenterhooks. We don't know how to plan. We don't know how to staff.
And probably have even less of an idea what to expect next winter.
Yeah, well, I think the one thing we can expect is that if it doesn't show up this summer, then next winter we'll have two whole cohorts, two whole age groups of people who are completely susceptible to RSV, and we're going to have a very, very bad season. Because normally, our 1 to 2 year olds are partially protected by their exposure the year before, and our 3 to 4 year olds don't get very sick with RSV because they've already had it once or twice. That's all out the window now, and all young children are going to be susceptible.
And at the same time, we, as far as we can tell, looking forward, SARS-CoV-2 in some form will still likely be a player.
I think that's become a very safe bet. I think between its rate of mutation, the amount of disease in the world, the fact that very few countries are going to really get the kind of vaccination levels that we want, some for economic reasons and some like ours maybe for more political reasons. I think this virus is going to be with us for the foreseeable future, maybe for the rest of our careers.
I heard an epidemiologist earlier today say for a generation or two, and my heart sank a little.
Yeah. Yeah. My wife always kids me that I have a full employment plan.
and then some. Well, thanks. Thanks again. We'll suspend our talk here, and then we'll come back and try to project going forward what the future holds. Thanks for your time, Andy, and thanks for spending a little. Thanks for sharing your expertise.
Well, thanks so much, Paul. Thanks for all you're doing, and thanks to everyone out there who's listening.
Okay, we're back with Andy Pavia, who never sleeps, and he is so kind that he is spending a little bit more time with us talking about SARS-CoV-2. You've heard of that virus, apparently?
Yeah, I've heard it was a hoax.
It's been Yep, it is. It's a complete hoax. And let's just talk about the moon landing now. Do you have any conflicts you want to talk about?
I don't have any conflicts that are relevant.
Okay. Well, let's talk a little bit about what we should expect going forward. I think that primary care offices have done a remarkable job, in my view, of pivoting through this whole thing to try to take good care of their patients while also keeping them safe and also trying to diagnose and treat virus that's new in their domain. Um, I'm sure that you have information about challenges that have shown up with kids getting their regular immunizations and well checks, and that's been a challenge.
Yeah. Well, so first of all, I agree that my hat's off to everyone who's managed their primary care practice during all of this. It's been really challenging, and people have done a good job. Yeah, one of the challenges, of course, is going to be to do catch-up immunizations. We know that immunization rates have fallen behind because parents haven't brought their kids in or their kids have been sick. Another challenge is going to be for the adolescents to fit in their 2 doses of SARS-CoV vaccine amid their other adolescent vaccines. Hopefully, it's not a problem for those who've already had all of them, but for those who need the full set of adolescent vaccines this summer, there's going to be a number of trips in, because I think we're still going to be recommending separating the SARS vaccines from the others by 2 weeks. What I will say is that I think where we have flexibility is that it's not absolutely essential that you get your Pfizer vaccine exactly 21 days after the first dose. We know that that's the earliest you can give it to get good protection. But if you need to delay things so that you can get your Tdap booster and your HPV vaccines in and get the second dose of SARS-CoV later, that's going to be a perfectly reasonable strategy.
And do you foresee SARS-CoV vaccination moving into offices at any time soon?
Yeah, probably next week. So right now, the state health department is really pivoting to making vaccine available to any provider that wants to sign up. And the process apparently is not that difficult. I haven't done it myself, so I take that with a grain of salt. Not that difficult for, vaccine paperwork as a relative term. The challenge, I think, to do it in the office is going to be how much vaccine can you handle and give in a week? And we're going to have to go through that pretty carefully. For some practices, it's going to be pretty easy because they're part of a large group practice. The pharmacy will manage the vaccine. They don't have to worry about how many doses they're going to kids because it's also going to adults in the other parts of the clinic. I think for a small practice, it may be difficult. Once you thaw a vial of the Pfizer vaccine, it's 10 doses, and you'd like to be able to use all of them. The good news is it's free. As everyone who's managing vaccine in their practice knows, you bought it, and if you waste it, it's money out of your pocket. And that isn't going to be an issue here because there is no charge whatsoever to having the vaccine in your office. But of course, there'll be record keeping, and there's the usual monitoring the temperatures and stuff. I'm not going to comment on the freezer requirements because by the time this podcast drops, they're going to have changed. So it will be easier, but not necessarily easy.
So it's all a matter of degree and degree.
Yeah. Right. I mean, it may not, you guys have managed having 10 different vaccines in your fridge and keeping up with the storage requirements for all of them. So you understand it far better than I, but it is probably not going to be orders of magnitude more difficult because you'll be able to store it for up to at least a month in a regular freezer.
Oh, really?
And it may be up to a month in refrigerator temperatures if the FDA approves the proposed changes.
Oh, very interesting. Some other things that have changed, of course, have been that, when we see symptoms suggestive of COVID-19, we've introduced testing to a much greater degree than we have in the past. Do you foresee that going forward for people with respiratory illnesses?
Well, we really, yeah. I mean, this winter we thought it's going to be super important to test because you can't tell RSV from flu from COVID, and RSV and flu, as we talked about, never showed up. So it became sort of easy. It was either rhinovirus or COVID. But I suspect that this winter, we're going to have the full complement of our old friends circulating. And I think testing will be more important than ever. An interesting clinical aspect is, what do you do with a fully vaccinated 14-year-old with a cough and fever? And there's still some chance that their illness will be due to COVID, but it's going to be much, much less likely. And, it may not be as much of a knee-jerk response to test every fully vaccinated person with mild symptoms for COVID as it was this year. But I do think office-based testing, or close to the office, convenient testing, is going to play an important role.
In general, in the past, testing for specific viruses has generally made most sense if it's going to affect what we're going to do with that patient. Do you foresee maybe more need for RSV and influenza testing going forward to help differentiate in the coming season?
It's a great question. As far as the SARS-CoV testing, if everyone in the family is vaccinated and the child's going to stay home and they're doing okay, you don't need to know. You need to know if they want to go back to school. You need to know if grandma has breast cancer and is living in the house with them. So you're going to have to assess what you would do differently if you know about the SARS diagnosis. For flu, I'm a big proponent of treating high-risk kids because that's, of course, the recommendation. So if the child has asthma or is under 2, you want to know if they have flu. RSV is tougher. If they're doing okay and you're not admitting them, there's no real benefit to knowing it's got RSV. If they're going into a shared room in the hospital, we absolutely have to know so they don't spread it. But for kids who you're treating and sending home, unless it's going to make the parents much happier and prevent that antibiotic prescription, knowing they've got RSV isn't that important.
So you're saying a certain amount of cognitive pediatrics is still in play?
Yeah, we still have to be doctors, damn it.
It's so complicated.
Yeah. But I think you can think it through fairly straightforward. Kid under 2 probably have to test because you would treat the flu and you would be a little bit concerned and watch them much more carefully if it's COVID, and focus much more on the respiratory secretions management if it's RSV. A healthy kid, 5 to 15, who's not going to expose other people with no asthma, no underlying risk factors, it's probably less important. But for all your asthmatics, diabetics, kids with congenital heart disease, again, it becomes pretty important.
How long do you see the mass testing continue to happen?
I think we're going to move away from mass testing. It's hard to predict what's going to happen in the fall at the schools because there's both public health questions about what makes the most sense, and then there's political questions about, what might get legislated. But I think there'll be somewhat less testing. Where there may be testing and where it may make sense is for those settings we're going to have a lot of kids gathering in close spaces. So, it's just not possible to have a safe basketball tournament or wrestling tournament if 100% of people aren't vaccinated without some degree of testing. So that may be the kind of place we start using it.
And there seems to be much more will for testing right now than there is requiring immunization.
Yeah, it kind of depends who you're talking to. Of course, talk to the public health people. We think you need both. Right. Immunization ultimately is the big deal, but we still need to know where the virus is. We need to know who's got it. We need to stop spread. It may become a lot more important to do testing once the virus is sporadic. I mean, we're already beginning to see a move from sort of large amounts of spread throughout the community to focal outbreaks. I think many people have heard about the outbreak at Elk Ridge Middle School, which maybe was quite a large outbreak at a middle school, but most schools are not experiencing much COVID. And that may be the pattern we see next winter of potentially limited number of explosive outbreaks. And we want to find those and stop them and prevent them from getting really big. So that's going to require testing.
And the testing, who will be directing that testing? Will that be directed from the schools? Will that come from the health department?
Well, the health department hopefully will create the strategies, and then the schools will do the hard work of implementing it, just like they did this winter.
You do all the hard work. What should families expect going back to school in the fall? We're just finishing this school year. We'll take a breather, but what should they expect going back in the fall?
Well, I'll give you my fantasy version first, and then my best guess about reality. My fantasy is that everybody 12 and up is vaccinated. And then middle school and high school will be just like it was in 2018, 2019. There'll be no worries, there'll be no outbreaks, the teachers will be safe. That's not going to happen, right? I mean, I hope that we could get there, but it's less likely. Uh, I think what we're going to see is very uncertain because we know that school boards make very different decisions in different school districts. I think we're going to see a hodgepodge. Some schools will probably maintain, some masking for tightly crowded activities and testing for unmasked activities. Some schools are going to throw away all restrictions. The best thing we can offer our kids, I think, is to get them vaccinated. So regardless of the policy, they don't have to worry, and their grandparents and their other vulnerable family members and friends don't have to worry.
So, if you have a vaccinated 12-year-old going back to school this fall, would you recommend that he or she wear a mask?
That's a great question. I don't have the right answer to that. I think if we had classrooms with very high rates of vaccination, that routine mask wearing is probably not necessary. The question is whether we'll have classrooms with really high rates of vaccination, because remember, the vaccine gives you very good protection, but not perfect. So then it's a combination of how likely you are to get exposed to the virus, how close is that exposure going to be, and how good's your vaccine protection. So, if there's only going to be rare cases of disease in class, and it's probably not going to be a really intense exposure, vaccine's going to give you great protection, and you probably don't need the extra layers of a mask. But if you're, the only kid in the classroom who's vaccinated and COVID's moving through the classroom, an extra layer of protection is probably still wise.
Now, let's say you have a fourth grader, a 10-year-old who's not eligible for immunization yet. Mask or no?
As of today, and I reserve the right to change this because we've been wrong about lots of things.
Right.
But assuming there's still community transmission, with a couple hundred cases a day, I think masking in elementary schools for the unvaccinated grades is probably a good idea for indoor activity when they're close together. We know it works incredibly well. We've been able to keep elementary school students in school and safe with routine masking. In states where masking has not been done effectively or not been done in schools, they've had lots and lots of school closures, or they've kept their schools closed for most of the school year. So the benefits are huge. It's kept our kids in school and it's kept them safe. Now, the reason I'm not so sure where we're going to end up is, we could see a fall surge. If we don't vaccinate well and we start to move back indoors in the cold weather, we could have potentially a surge in the fall or winter. On the other hand, we could also do a really good job with vaccinating, and we could have almost no transmission in the community in the fall. And those are two really different scenarios.
Is it safe to say that you would agree that maybe perfect attendance awards should go away, and that encouraging sick kids to stay home is probably a good idea?
Encouraging sick kids and sick workers and sick doctors and sick nurses to stay home is always a great idea. It's just not so easy to pull off.
I was just going to say, I was wondering whether we've done any better during this last season, but most of us didn't get very sick this last season. I think I had a perfect attendance award this year, and because I was in PPE and
Yeah.
careful all winter, I stayed well.
Well, you and I, we're old pediatricians. We have super immunity. But the really interesting group to look at was the house staff. They're usually sick as dogs. And, the absenteeism rate in the house staff is usually high because they get exposed to every virus that comes through the hospital and the clinic. And this year, there was very, very little respiratory disease in those, those canaries in our coal mine.
It works. It turns out that I think for whatever reason, we had fewer exposures, but I think that people were more cautious in very sensible ways, and I think it makes a difference.
A question that I've been asking myself, and I think we're all asking is, should we be masking routinely as providers during respiratory season? And should we be having our sick patients and their parents mask in the waiting room? Even without COVID, I think that there's a lot to be said for it. Now that masks are, socially acceptable, at least in parts of the state, and we know they work, I think we could cut down a lot on absenteeism and respiratory illness with some good respiratory etiquette.
Well, you just anticipated my last question. Should I wear a mask during flu season next year? And furthermore, not just in clinic, but should I model what so many people in the world have done in the past during flu season, wear a mask when I'm out shopping?
Yeah, the first one I think is easy. And I found it so much easier this year just to walk in every room with a mask on compared to deciding, does that kid have a fever? Does that kid have a cough?
Yeah.
Do they have a negative respiratory test? And deciding whether to put on my mask based on that. It was just mask on all the time. I think, in a practice, that would be a pretty easy thing to do. You miss the chance to smile at your patients, and that's tough. Yeah. But I think that could work very well. The grocery store and the subway and that sort of thing, I think it's not a terrible idea. If I was particularly vulnerable, even vaccinated, I would do it. I would advise, elderly folks, cancer patients to mask all winter. I think that's a terrific idea. And I think for others, I think it's worth thinking about.
And let's be honest, we've all acquired a pretty good collection of masks now.
That's right. I mean,
it seems tragic.
There's some people who have invested so much money in beautiful high fashion masks that it'd be a shame to let them go to waste.
No question. Well, thanks so much. I know you're very busy. Thanks for taking some time to educate us. I really appreciate all you've done through this year. I know this is, since we'll never have another pandemic again, I think that, I guess that should be my last question. If the flu went nuts next year, would we do any better?
I hope so. I think it's going to take us longer than that to really get ready and prepare for the next emerging infection. I hope we can do it. We've learned we have a lot of experience that we can turn into lessons learned, but it also requires, money, dedication, healing some of these political rifts. Never again should a disease be a political issue if we can contain that. And Paul, I wanted to end by thanking everybody who's listening, because I think there's been a lot of attention to us, quote unquote, frontline workers in the hospitals and in public health, but it's been an incredibly hard year to provide every other form of healthcare for people. And, I think particularly people who care for children in primary care setting, it's been a really tough year, and a lot of what you've done has been heroic as well. So thank you.
Yeah, but it's still a great thing to do. So that's where the satisfaction is. Thanks so much for your help, Andy. Wish you much health and safety, and hope for a speedy end to all of the ills you just described.
Thanks.
Look forward to you again in the future.
And let's go out there and get all of our patients vaccinated.
Absolutely. Thanks again.
Thanks.